What are the non-modifiable risk factors for cardiovascular disease? Cardiovascular disease can be caused by a variety of risk factors we cannot control. The older you are, the more prone you are to chronic conditions like heart disease or stroke. However, men have a higher risk of cardiovascular disease earlier in life, while women are more at risk after menopause. Women may also experience different symptoms of heart attack that may go unrecognized. You may be more at risk depending on your ethnicity. People of Asian, African, or First Nation descent have higher rates of cardiovascular disease. Your ethnicity may also influence your diet, which can put you at an increased risk for cardiovascular disease. If you have a first-degree relative who has had cardiovascular disease or a stroke before the age of 55 for men and 65 for women, your risk of heart disease doubles, and regular screenings with your doctor are recommended. But there is good news. Up to 80% of premature cardiovascular disease can be avoided and more effectively managed by taking these proactive steps. Quit smoking, be physically active, eat well, achieve a healthy weight, manage your stress and any anxiety or depression, and see your doctor about managing your cholesterol, blood pressure, and blood sugar levels. For more information on cardiovascular disease, please visit our website.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.
Hello, and thanks for tuning in to Beats Research Radio. My name is Hallie Arnott, and I'm the Canadian Biomaterials Society Ottawa Student Chapter President and a graduate student in Biomedical Engineering at the University of Ottawa. Today, I'm back here with you at the University of Ottawa Heart Institute, streaming from an active lab. Our goal here at Beats Research Radio is to communicate the research that's being done in the medical field and explain how that makes its way into the clinic and translates to patients. Before we get going with our interview today, I'd like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society Ottawa Student Chapter, and the Department of Biochemistry, Microbiology, and Immunology with the Faculty of Medicine, and who are supporting us here at Beats Research Radio. Also, don't forget to subscribe to our YouTube channel as well. You can visit our podcasts on Spotify, Apple Podcasts, and Google Podcasts. Sitting with me here today is Dr. Andrew Krahn. Dr. Krahn is a professor at the University of British Columbia in the Division of Cardiology. He's also the Chief of Cardiology at UBC. His current research interests include the investigation of the genetic causes of arrhythmias and the cause for loss of consciousness due to arrhythmias, as well as implantable arrhythmia devices. Dr. Krahn's research is funded by the Heart and Stroke Foundation, as well as the Canadian Institute for Health Research. In addition to his research, Dr. Krahn is the founder of the Hearts in Rhythm organization, which is a Canadian network of inherited arrhythmia clinics. Dr. Krahn is also the president of the Canadian Cardiovascular Society and the second vice president of the Heart Rhythm Society. So thank you very much for joining us here today on Beats Research Radio.
Great. Love the show name. Beats for a heart rhythm doctor. It fits perfectly.
Great. So our first segment here, we're going to be talking about cardiac arrhythmias and what are they. So would you mind telling us a little bit about what a heart arrhythmia is?
Sure. I mean, arrhythmia, if you like, means that the rhythm isn't quite normal,
Mm-hmm.
and the heart has a rhythm. Think of it a little bit like a lighthouse or a spark plug that fires every
Mm-hmm.
second or so. It speeds up when we're more active, slows down when we're relaxing or sleeping.
Right.
And arrhythmia means that something's wrong with the rhythm. Sort of simply falls into two categories. One's too fast and one's too slow.
Okay.
We're usually most concerned about too fast because the fast ones are the ones that can be dangerous.
Mm-hmm.
Too slow can sometimes cause people to be tired or faint, but they're usually not dangerous.
Mm-hmm.
But that's the sort of bucket of heart rhythm problems.
Okay. And what would be the warning signs for someone who has an arrhythmia?
It can be a range of things. It sort of speaks to this question about how dangerous or how concerning it is. So a good example is most people who have a slow pulse, they can at times feel dizzy or faint. They can pass out. Typically when that happens, the heart's slowed or stopped for at least a few seconds. But the heart typically starts itself back up, if you like. And so we look for evidence of heart slowing when we inquire about dizziness or fainting. And sometimes the heart's inability to speed up means the patient can't exercise or be as active as they want to be.
Mm-hmm.
When the heart goes fast, when it goes somewhat faster, oftentimes patients feel a little bit unwell. They can feel palpitations or pounding in their chest.
Okay.
They can also feel out of breath or lack of energy or those kind of things. When it goes very fast, the heart doesn't have enough time to fill or empty properly, and then they can faint, they can collapse, or in layman's terms, if like they can collapse and not wake up, they can drop dead.
Right.
We call that cardiac arrest. Most people think when you hear somebody who collapses, for instance, out in public, that cardiac arrest is the heart stopping, but it's actually going so fast it's not pumping.
Oh, okay. Wow, that's very interesting. I didn't know that.
Yeah.
So in Canada, I know there's a couple types of arrhythmias. What would be the most common ones we see in Canada?
Probably falls into three main buckets. So the first one that I talked to about the heart going slow, especially as we get older, the heart's more prone to go slow. And so you'll hear about people who felt unwell in some way and then got a pacemaker. Pacemaker is the usual treatment for a heart being too slow. We don't have a pill for that.
Mm-hmm.
So one is the heart's going too slow. The second one that is the most common rhythm problem we have is called atrial fibrillation.
Right.
So this is sort of a fast and irregular heart rhythm that comes from the upper chamber of the heart. Mm-hmm. It's not dangerous in the moment, but patients will often have palpitations and breathlessness, and with it comes some risk of the heart getting weakened and getting what's called heart failure, or a risk of clot, what's called or a stroke.
Okay.
So one is heart slowing. The second one is a fast and irregular pulse called atrial fibrillation. Mm-hmm. And then the third one are the dangerous heart rhythms, the ones that come from the main pumping chambers of the heart.
Okay.
And those are the ones that are associated with collapse and sudden death.
Okay.
So there's a whole realm of what's called cardiac arrest or sudden death. And so when you hear about somebody who died in their sleep or collapsed at the mall and they couldn't save them, that's called cardiac arrest. And that's the third type of rhythm problem.
Okay. And you're interested in inherited arrhythmias. Are these, so they're genetically involved? How are you able to diagnose someone with an inherited or genetic arrhythmia? Does it happen at birth, or is it developed later on?
If we think of, so I've been interested in the whole realm, if you like, of genetics in the heart, and we inherit a bunch of things. And so, for example, we inherit our cholesterol is often determined a lot by our genetics. That's not a focus for me, but that's something that we inherit that predisposes us to heart disease. We inherit some of the traits of things like our heart muscle parameters, and there are conditions where you can inherit a problem with the heart's muscle. Those are often show up at different stages in life, including in childhood at times. But oftentimes it takes the heart some time with development to sort of develop away from normal or into the problem. Okay. And so it's not something that is common in infancy or childhood. It shows up more with adolescents or young adults. On the heart rhythm problem, if you like, if the problem's not plumbing but wiring, on the heart rhythm part of things, again, most of the time the problems start to show up in school-age kids or teenagers and sometimes young adults. Occasionally we'll see them start in life in middle and even later in life as well. Okay. So they come to light several ways. One is when something's happened to the person, and a good example is a person faints. And when the person faints, they have an evaluation, and the medical evaluation shows an abnormal test it raises the question whether they have one of these inherited problems.
Okay.
Second thing is the patient has some kind of medical encounter and a test is done. And so a good example is you have a fall or an injury and you go to the hospital and they do an EKG, and the EKG shows a change in your tracing that suggests you were born with some problem with an electrical component of your heart's rhythm. And then the third thing that happens is we see people where something's happened in the family. My cousin who lives in Calgary collapsed and they told her she has long QT syndrome. And they say that I'm at risk. Can you evaluate me for that?
Right, okay. So these three buckets that you were talking about before, the main arrhythmias that we see in Canada, is there more often one of these types of arrhythmias that show up genetically than another type of arrhythmia?
Probably the single most common one is a problem with heart's muscle called hypertrophic cardiomyopathy.
Okay.
And there's a whole domain, if you like, of heart muscle problems, but that's by far the most common one. Next in line would be one of those electrical problems, and that's called long QT syndrome. So as a person who runs a clinic that has a focus more on the electrical parts of things, I feel it's most important and common. But I have counterparts who have more of a focus on the heart muscle problems, and they obviously also feel that's more common. These things are responsible for several thousand deaths in Canada every year, so it's very important to both be aware and then try to identify families where this happens and try to get ahead of those tragedies rather than let the tragedy make the diagnosis.
Right. And is there something specific about a genetic arrhythmia where you see someone with an arrhythmia and there's something where you say, okay, we need to test the family, and this is possibly genetic, or is it always tested as a genetic disorder when someone in your family develops an arrhythmia?
Well, it's a good question. So, unfortunately, as we get older, if you like, some systems, if you like, wear out. And so, for instance, atrial fibrillation commonly happens when people are in their 70s or 80s. By the time we're in our 80s, 1 out of 10 people has it. And that's a sign of aging and not something that's particularly genetic. When atrial fibrillation happens in somebody who's 25, we're very suspicious that it's genetic, and it's much more common that, for instance, they're going to have family members who are affected or things like that. So there's a context that's very informative to this. For some other things, for example, these electrical abnormalities like this long QT syndrome I talked about, or the hypertrophic cardiomyopathy, in those situations, the nature of the heart tests is actually typically raises suspicion. We have a network of clinics across the country that have an interest in this area that see patients and then their families. And one of the key reasons to do this is not only to diagnose the person in front of you, because they may or may not have a problem or have risk or so on, but the key thing is to get to the family. And one of the main reasons for that is because we have lots of good treatments that can be put into place that prevent patients from ever having risk or getting into trouble. And so, for instance, in our clinic, we will see families where something terrible's happened. There's a tragic death of a young person. But most of the time we see people where we've said, you know, your cousin in Calgary didn't collapse and die. Your cousin in Calgary had one of these tests that's abnormal, and we now know that it's genetically mediated. And we know that if you come for instance, an exercise test and where we collect a little bit of spit, we can get your genetic information and we can tell you whether you have risk. And then the treatments are very simple. There are things like small lifestyle suggestions or a once-a-day pill. And those patients are functionally protected from ever having a dangerous heart rate.
Okay. So once you have this genetic information, what's the process of going through that testing? How does that happen?
So one of the interesting things that's a characteristic of our modern society is that we have a really robust privacy system.
Right.
So, for example, I'll take an example. Let's say that you were diagnosed with one of these problems, and I say to you, well, your family should be checked. And I think of it as kind of like spokes on a wheel. If you have kids or siblings or parents, all of them should be checked because they could have a risk of the same thing. I can't call them.
Right.
You are the conduit. So we rely on you to be our family champion.
Right.
And you can imagine that if you do this enough, you find some people who are very private about it, some people who don't get along with their family, some people who don't understand that their family is at risk, and so on. So we have genetic counselors whose job is not only genetic expertise, but also working closely with people to communicate with them.
Right.
It may seem very simple, but for example, in our clinic system, one of the things that's, if you like, the genius of the clinic is not the smart people who work there. It's actually our ability to do things like when we see people, we email them information about themselves that they can send to their family.
Right.
We give them a piece of paper because some people still like an analog communication.
Definitely.
We send out a reminder 2 weeks later to say, did you get a hold of your sister? Is there
Mhm.
anything we can do to help? We see them again even though their health is fine, because an in-person reminder is more effective than an email. It's saying, you should make sure that your sister and her kids are also assessed and safe.
Right.
So they understand it's not just about them, it's also about the family.
Okay. So do you find that more often than not people do follow up with their family, or are there some cases where you've seen a family member and then maybe a couple years down the line somebody else comes in from that same family and we're not in the know?
If you think about a family as a little bit like a tree, you can imagine most of the time they've done something to connect with an individual in their family, but most of the time it hasn't been complete.
Mm-hmm.
And so a good example would be right after they are seen the first time and we make a genetic diagnosis, then it's clear to them, they're sort of motivated at the time. So we'll send them materials or a reminder and give them to them, and then they send them out.
Right.
And so, for example, we send a letter that summarizes their case and says, give this to your sister, who takes it to their doctor, who asks, and then their doctor has to ask us to see them.
Okay.
We can't solicit that referral. They have to actually
Right.
ask to see us. So we often get our own letter back saying, please see, her sister, kind
Mm-hmm.
of thing. But what often happens is it stalls either at the sister or it stalls at the family doctor.
Mm-hmm.
And so we have this reminder system. But when we look at all of the people in a family tree who are at risk, there's always a few people who don't quite trickle in.
Right.
We have one of the things about our healthcare system is it's very provincial. So if I say I've seen somebody, I'm from Vancouver, I see somebody from Vancouver and their cousin lives here in Ottawa,
Mm-hmm.
right? So then that's another burden of we need to release of information to permit record transfer, so they know exactly what to look for and how to check them and so on. And so all of those things require somebody to manage the case and not just be passive about it, because
Mm-hmm.
it's less effective when it's passive.
So when someone has this arrhythmia, implantable devices is another realm of your expertise. How does somebody go about getting an implantable device? How are they implanted? Where are they implanted?
Yeah. So the implantable device people are most familiar with is a pacemaker. It's used to treat heart slowing. That's predominantly an issue as we get older. The second one that people are becoming more familiar with is called a defibrillator, or ICD.
Okay.
And this is a device that's essentially waiting for a dangerous or life-threatening rhythm problem and can give a shock like the ambulance does. What's different about those devices is that instead of waiting 10 minutes for the ambulance, you wait 10 seconds. And if the device says, listen, this is a fatal rhythm problem, I need to give you a shock, it does it right away.
Exactly.
Those are selected in people who have some significant risk that they're going to have a life-threatening rhythm problem, or they've already had one.
Mm-hmm.
So that usually is a recognized heart disease or a concern about something. What's cool, and started for me 25 years ago, actually, are these little forms of different heart monitors. And we can talk about the ones that are worn on the outside are the wearables, but the ones that are on the inside, when I started, we were literally working on a prototype of a device that looked like a pacemaker. It's sort of, about this big.
Mm-hmm.
And then we came up with one that looks about the size of a little USB drive.
Mm-hmm.
And then the latest ones look like paper clips.
Right.
So we're now able to inject a heart monitor that works for 3 years, that records your heartbeats, that you can interact with. And it can actually send us information either through your phone or through a modem-based recording device.
Kind of, or...
So the very latest version have Bluetooth capability.
Wow.
And that allows us, for instance, to look for warning signs, or if, for instance, if you have fainting, to record what happens when you faint, those types of things. They're still a little bit invasive in the sense that it takes like a little sort of miniature injection operation done at a hospital.
Okay.
And they're still expensive because they're very novel technology that's very capable. But we are now able to get information we haven't had in the past about what's going on with people's cardiac status.
Right. So these injectables, is that all across the board? Anyone who is going to be getting a pacemaker, they would receive this injectable transplant, or are there still other types where we have to open up the heart?
Yeah, all of these devices are done as day surgery, quite frankly. All those three things I talked about. So, for instance, most patients who have a pacemaker, unless they've been hospitalized with a problem, they'll have the pacemaker put in and go home on the same day. These injectable devices literally could be 30 minutes at the office or the hospital. That's how simple they are. And in fact, one of the advantages to some of these things is it's no longer 7 days in hospital and all of the involvement and costs and logistics of that. It's literally like a day procedure. So we have a lot better range of internal technology, but we also have external technologies.
Right.
And that sort of that blends, becomes very gray about how much of that is medical technology versus what's called consumer technology and the external wearable realm.
Right. Yeah, in terms of the external wearable realm, I have a question about that. But before I ask, how do you see this internal technology moving forward in the future? A paperclip is extremely small. How much smaller are we able to get here in terms of a pacemaker?
So the irony is, there are new types of pacemakers. So typically a pacemaker is something that sort of looks like a toonie,
right?
And then it's got one or two wires that connect to it. So we make a little cut under the skin here, put that little toonie under the skin, and then connect it to wires that go in kind of like an intravenous.
Okay.
So a pacemaker takes an hour to an hour and a half to put in. It's pretty simple. People don't go to sleep for it or anything like that. It's a very small operation.
Okay.
But the interesting thing is the miniaturization process has now led us to create something that's literally about this big. That can be, if you like, put into the heart. We put a catheter or a little tube, puts this thing into the heart, literally screw it into the heart muscle and let go. So it looks like a little capsule. That's the whole pacemaker.
Wow.
So no battery, no operation, just a little nick in the leg where it goes into the vein. Pass it up into the heart and leave this little pacemaker there. Wow. It's incredibly cool.
So back to the wearable devices. So Apple keeps coming out with these watches, and now recently they've come out with the one that can monitor your heart and also detect when there's an abnormality. And specifically, I think the study that they came out with Stanford University, they were able to detect atrial fibrillation with 84% accuracy. Do you think that this device is going to be useful for those people with arrhythmias, or possibly genetic arrhythmias that they aren't aware of, and that might be a first step to going to your doctor and saying, my Apple Watch is telling me something's wrong?
Well, I was at the Apple Watch presentation in March where they presented it, and it still hasn't completed its process and published. But long and short of it is the device is pretty good at detecting atrial fibrillation. And the study was looking at basically trying to take healthy volunteers who weren't known to have atrial fibrillation and see if they could pick it up.
Right.
There's a whole realm of huge number of studies going on right now to see the utility of this as a sort of health check system. And there is no doubt that this is coming. We have atrial fibrillation clinics. I work in an atrial fibrillation clinic, and about a month ago in that clinic, I had 6 patients who brought me their health data from an Apple Watch or a Cardia. There are several different sorts of platforms for the ability for them to get their own health information and then bring it and say, here's my problem, or what should I do about this, or this kind of thing. A real change in sort of who owns health in a good way, but also the ability to detect things. We personally, back at home, have several studies going on right now where we're using these kinds of patches and watches and things like that to determine whether they're useful and accurate for the genetic conditions.
Right.
So if you heard me talk about long QT, this is something where the EKG shows a longer interval for the heart to get ready for the next heartbeat.
Right.
And that's something that we can measure. As a biomedical engineer, I'm sure you'd be interested in that. So we're now looking at whether these monitors are accurate the way conventional medical testing is to tell us if the QT is too long or not.
That's very interesting.
And part of it is the whole idea. Here's I think a bit of an innovative concept is historically when there's a question about your medical health, you come to the hospital and they do a bunch of tests and you see the doctor and this kind of thing. We're looking, if you like, to mail or digitally send materials to collect the health information at home. And then, so for instance, 20% of our patients are seen by Skype.
Wow.
Or telehealth. So so we're literally talking to people for their health encounter when they're in their house.
Wow. That's great. Our medical industry and our clinics are just evolving, and this is, I think we're going to see a lot of changes with genetic arrhythmias. And these clinics that Dr. Krahn is talking to us about, we're just going to get back to those in our next segment. So thank you for tuning in to our first segment. We'll be back in just a few short minutes.
Your body reacts to changes physically, mentally, and emotionally. These reactions are called stress. Sometimes it can be a positive thing. It keeps us alert and aware of potentially dangerous situations. But stress can also be bad. If you're ignoring stress symptoms in your habits and attitudes, going long periods of times without relaxing, you may actually be doing more physical damage to your body than you think. Headaches, upset stomach, high blood pressure, chest pain, and problems sleeping are all symptoms of a high-stress lifestyle. Stress can worsen skin conditions, heart problems, diabetes, depression, and anxiety. Stress is a normal part of life. Everyone deals with it, but not everyone deals with it the same way. Sometimes your interpretation of a stressful situation can make it seem worse than it is. Ask yourself, how can I change my reaction to this situation? You can prevent unnecessary stress by learning to say no. Don't take on more than you can handle, and ask for help when you need it. Don't procrastinate. Manage your time and your energy effectively so you don't end up feeling overwhelmed. Many people tend to neglect their diet and exercise habits when they become overworked and overstressed. But healthy eating and physical activity can actually be used as a way to cope. What else can you do? Laugh. It brings down your blood pressure. Make time for you. Don't bottle up your feelings. If it's bothering you, say so. Be positive. Avoid telling yourself things like, I can't handle this, because the truth is, you can. Do one thing at a time. Reward yourself each time you accomplish something. Take slow, deep breaths and visit francoform.ca. What is blood pressure? As blood circulates through your body, it exerts pressure against the walls of your arteries. That pressure is what is measured with a blood pressure device. Blood pressure is measured by two numbers. The top number is called systolic and measures the pressure in your arteries when your heart is pumping. The low number is called diastolic and measures the pressure in your arteries when they are resting and refilling. High blood pressure is something you need to avoid in order to keep your heart and arteries healthy and clear of any cardiovascular disease. Blood pressure is always best measured at rest. Ideal blood pressure is 120/80. Your blood pressure should be less than 135/85 in the comfort of your home and less than 140/90 elsewhere. If you suffer from diabetes, your blood pressure should always be lower than 130/80. If your numbers are consistently above these targets, you should consult your doctor. It is very important to take your blood pressure following these easy instructions. Sit comfortably in a chair that offers good back support. Uncross your legs. Place the proper size blood pressure cuff on one of your arms. Put your arm on the armrest so that the blood pressure cuff is at the same level as your heart. Relax for 5 minutes and do not talk. If you have time, take your blood pressure 3 times. Discard the first reading and average out the second and third readings. Keep a log of your readings for your doctor. The trouble is, high blood pressure isn't always noticeable. Sometimes called the silent killer, people can go years with high blood pressure and never know they have a problem. High blood pressure makes your heart work a lot harder than normally and causes added strain to your artery walls. Over time, this can contribute to the buildup of plaque, restricting blood flow throughout your body, which can lead to coronary artery disease. If the artery becomes fully blocked, you could have a heart attack. So what are all the health risks associated with having high blood pressure? Stroke, heart attack, heart failure, dementia, kidney disease, eye problems, erectile dysfunction. Having a health professional check your blood pressure is a way to find out if you might have high blood pressure. but logging your home blood pressure will also allow your doctor to determine if you have high blood pressure. There are numerous devices recommended by Hypertension Canada that allow you to measure your blood pressure at home. Be sure the device has a logo indicating that it meets the standards of Hypertension Canada. Discuss with your doctor to learn which device is best for you and how to use each of them properly. If diagnosed with high blood pressure, your doctor will have you focus on these 3 areas of lifestyle change in order to help lower your blood pressure to a healthier level. Quit smoking, exercise 30 to 60 minutes a day most days a week, eat more fresh or frozen vegetables and fruit daily, choose lower fat milk products, whole grains, lean meat, fish, and poultry. Limit sodium intake to no more than 2,000 milligrams a day, cook more at home, and eat less processed foods. In some cases, these changes are not enough, and medications will be needed to help combat high blood pressure. If you have any questions or would like to learn more, help is just a click away.
Good morning, welcome back to Beats Research Radio. My name is Hallie Arnott, and I'm sitting here with Dr. Andrew Krahn. If you missed our first segment, Dr. Krahn is a professor at the University of British Columbia in the Division of Cardiology and the Chief of Cardiology at UBC. His interests include cardiac arrhythmias, especially those that are genetic, and implantable arrhythmia devices. So in this segment, we're going to be talking a little bit about our understanding of these inherited arrhythmias. So first, could you tell us a little bit about what the Hearts in Rhythm organization is?
Oh, sure. Do we have all day?
Maybe briefly.
Okay. So I've been working for about 25 years since I finished my training and had an early interest in this whole area of genetics and heart rhythm problems and so on. And realized that the area of focus are things that are relatively uncommon problems. And for that to work, for you to kind of better understand that, you need to assemble a large enough group of people and patients and families and so on to really see patterns and understand how things work for them and so on. So early on, I began the process of partnering with other people, including here at U of O, but sort of initially a network in Ontario because I used to work in London, and then broadening it to be more national. Mm-hmm. And so we had, from about 2004 through 2014, we had a network of about a dozen clinics across Canada. And the research group was really fundamentally a bunch of physicians interested in how these conditions manifest in patients and families from a cardiac perspective. So this is heart tests kind of thing. How useful is the EKG? Is an MRI better than an ultrasound of the heart to detect this kind of inherited problem? Those kinds of questions. Mm-hmm. And I had sort of for me at least, an epiphany to realize that for this to really be more effective, to get past just the physician questions, it needed to involve more than just curious physicians. It needed to involve a whole range of different kinds of people. And if we think in terms of research terms, we need to work on discovery, on translation, on clinical application, on our health system, and so on. And then the other part of it is that this kind of notion that we know best or we understand the important questions ignores the patients and their families. Mm-hmm. And they're very important issues, and they should be more than research subjects. They should be involved and participants and even decision makers.
Right.
So that's quite different than the traditional model, because mm-hmm. it means people working with and interacting with people who don't have their lens on life. Mm-hmm. A patient's Definitely. Priorities are quite a bit different than somebody who's looking at stem cells, for example.
Definitely.
So that's one part of it. So then the other part of it was, as a person interested in the area, starting about 20 years ago, we began the creation of clinics, and clinics were basically assembly of a team with an interest in this area. So, for instance, that includes people from pediatrics, from adults, from genetic expertise, from nursing in principle, psychology, imaging, pathology, the coroner, a bunch of different kind of people around a team that delivers care to not only the person in front, but also their family. Mm-hmm. And so in Canada, if we go back about 5 years ago, by that point, what we had realized is about a third of places had a really good team clinic approach to things. A third of places were sort of trying with varying success, but a third of places was just some doctor who was interested.
Right.
And I said, we've got to raise the bar. And the whole goal of this is to try to create a network where patients everywhere have access to an expert clinic, and then the expertise within the clinic is improved.
Right. So the interdisciplinary approach in the clinic for the patients is what we're trying to bring here with this Hearts and Rhythm organization. Are you integrating these into the hospital? Are they standalone clinics? How are they integrated into medicine?
So these are all hospital-based clinic systems that are typically built around the key, if you like, unit of care delivery is a person from genetics and a person from cardiology.
Okay.
That can be pediatric or adult. The person from genetics is typically a genetic counselor. This is a person whose job is both genetic expertise and education. And they often have a medical geneticist, like, behind them that provides support or advice for difficult cases.
Okay.
And then the things that go around that aren't necessarily involved at the point of care but are important are things like expertise in things like MRI, ultrasound of the heart, pathology, molecular medicine, those components of things. And so we have team meetings where the traditional thing where you go into the doctor's office and there's an examining table and there's you and the doctor, our team meeting is our care process is a conference room. Because there's a mom and a dad and two kids, and then there's 4 or 5 of those different kind of people, maybe even sometimes plus some learners or researchers. Right. So the whole process of care is hospital-based, it's team-based, and it's quite slow and deliberate because we're dealing with a group of people at one time. So it's quite different than your typical kind of clinic encounter.
Definitely. So in these interdisciplinary environments, do you find that I guess everybody brings something niche and new to the team? Have you found that once you created this interdisciplinary environment, new ideas were popping up in terms of solutions for these patients?
One of the points I make is that no single person can deliver everything that a person and a family needs to understand and manage their condition. There's too much to know. There's a rapid pace of evolution of research, and what you want is deep expertise in areas, and what that means is there's too much to know, and as a result you need multiple experts.
Right.
So for sure, for instance, our clinic starts with that team getting together before the patients show up and looking at what we're going to do today and talk about what the key elements are, what we don't understand, what we need to inquire about. We make a plan in advance, if you like. And that reflects all of those things, like, for instance, somebody saying, we were going to talk to this patient about whether they should have the surgery for their implantable device. Or saying she's really struggling with the medication that we prescribed last time because she feels like it makes her tired and she wants to, she's not taking it, but she hasn't told her mom that, but she told me that.
Right.
Well, that's an important thing for us to try to address, but in a constructive way as a team, right? Not in a blaming way, but in a help us understand kind of way.
Yeah, that delivers definitely well-rounded care, I think, for the patient.
Yeah. The other part of that, I think that's important, is every time we see patients, we revisit their genetic information. And so many people think that genetic information is something that the test is yes or no, I have it or I don't. But in fact, genetic testing is much more complicated than that. It's often what's called probabilistic. It means the best explanation or the genetics support the condition, but it also actually changes over time. People don't believe that their genes change, but actually our interpretation of the genetic information changes because we learn more. And so, for example, what was thought to be probably the explanation for a heart problem 5 years ago, we know now that the likelihood that there's a different interpretation of that is about 20%.
Okay. Wow. So would there be a recommended time period? So if somebody in your family has an arrhythmia and you are possibly predispositioned for that genetic arrhythmia, would you say that person should come in for testing every 5 years, every 2 years?
Yeah. So this is precisely one of the reasons to create something like the Hearts and Rhythm organization or HERO, is it gets all of the national participants together to say, what do we think about how this should work? What does the evidence support? What are our standards for things to answer those types of questions? And so a couple little examples. One is we say if you have this condition called long QT syndrome, we now actually have a national registry for that. And that registry says those patients should be seen every 2 years or at the most every 3 years if they're stable, and urgently if they have some kind of change in their medical status.
Okay.
So that's one part of things, is setting those kind of goals and standards for how we do things and so on. That also helps to inform research because you collect useful information. The other thing that it does is it uses those kind of things to help start new clinics. So we've done that to say, for instance, there was a champion in Winnipeg who wanted to start a clinic there. And so they came to visit to see how other clinics do. We have a whole toolkit of things to provide to them for communication tools, health process tools, things like flow diagrams for when to see patients and booking processes, what budgets are, all those kinds of things. Wow. And so 2 years later, not only do they have a wonderful clinic, but they in fact won a local healthcare innovation award. Wow. For having gone from zero to a kind of a leading clinic in a short period of time, and that's extraordinarily rewarding.
So what caused you to found this organization? Is there maybe an example you could give us where you saw there was a gap in patient care, or maybe not patient care, but the process that somebody with an inherited arrhythmia goes through in the common medical stream?
It's not good to point out limitations too much, but when we had that group of physicians who were interested in doing research together, when we would meet and talk about things, when you'd hear about the process of care that happened in some of these places, you'd literally have somebody who comes to see the doctor, and then that patient is then sent to another city to see a person from genetics, who then has to go to a different hospital to then have their children assessed, who then has to come back. All of those constituents need to talk to each other and understand the components of the family in the context of a privacy environment that tells us not to talk to each other.
Right.
So you hear these anecdotes and say to yourself, boy, they really need the notion of creating a hub with the patient at the middle, not the provider at the middle, but the patient at the middle. And then what does that patient need for inputs with their family?
Right.
And so, if you like, my heart goes out to those situations where they haven't been able to create that system where a team is looking after these people. And so I said, we have to do this.
So your the Hero, it aims to provide quality care and standardized care. In terms of the standardized care, how do you use registries and biobanks? Is that implicated in the standardization?
So one of my philosophies, if you like, is that when you have research that's embedded in the clinical process, what you get is you get a team of people asking questions, and that curiosity then creates aspirations. I want to do better. I want to understand this. Why don't we have a good answer for this question? Those kinds of things. And so what we've done, and the principle of Hero, is to put the researchers in with the people who provide the care, in with the patients and the families and so on, so that those things are linked together. So when a patient comes to the clinic, for example, not only do we do their EKG and talk to them and make a plan or prescribe a medication, we ask them to participate in a registry where they're part of the learning process, how to be better at managing their condition. We use biobanking and ask them for typically a blood sample with the intention that their DNA can be informative to understand how the genes are contributing to risk or protecting from risk. And because some of their care now is because somebody did this 20 years ago. And we learned things from that now lets us know that they should or shouldn't take this medication or have this procedure. But the same thing happens now where I think our understanding of things is good but not great.
Right.
I have lots of questions that come up all the time. And I say to them, when I see a patient, for example, I'll say, I'm curious for you why it is that you've come in and you've had a problem with this, but we think your brother has the same genetic problem but has never had a problem. What's different about you? Because he's got something protecting him that didn't work for you. How do I take what he's got and give it to you?
Exactly.
And they say, oh yeah, that sounds like a
great
good idea. We solved that one because I don't want to have this problem. So, and that creates a different sort of cultural perspective for the patient. who doesn't sort of feel like they're a lab rat. They actually
Mhm.
feel like they're trying to answer the questions themselves or help to answer the question.
Right.
So I think linking those together kind of makes a team that involves the patients in answering those questions about their best care.
So patients who would have the inherited arrhythmia, do they become referred to your clinic from the hospital, from their family doctor? How do they become informed about this organization?
It's a good question. So for example, we have a website, and the website includes something where you can find a clinic. And one of my original goals when this all started was to say every Canadian should live within a couple hours of an expert.
Right. Yeah.
And, so that they don't feel that either there's no one there who can take care of them, or they don't have access to somebody who can provide direction to their local doctor.
Mm-hmm.
So that's a digital way to do that. Most of the referrals that come through these different processes, they'll come initially they'll come from specialists who know the conditions, and they're looking for extra expertise in the area.
Mm-hmm.
But as if you like, build awareness within your health environment, then it comes from emergency rooms, from family physicians, from non-experts who will find you or know about you. And so then one of the goals, of course, for Hero is to try to maximize awareness that, in fact, there are people and experts. A little anecdote, for example, is if somebody dies suddenly, it's a terrible thing, and that process then goes through typically an autopsy,
Mm-hmm.
and there's a coroner involved, and then those individuals communicate with either the family or the family doctor.
Okay.
So each of those steps means the probability of them not getting to see us is a big risk, is a big problem.
Mm-hmm.
So what we're trying to do in this situation is we're trying to connect all of those components so that it's automatic that when something bad like that happens, we see those families.
Okay.
And so our role is to try to facilitate that family doctors know, emergency room doctors know, pathologists and coroners know, because that will help us to find those people who are at risk so that something bad doesn't happen.
Right. So finding these people at risk, is it anyone who has had an arrhythmia and has gone into cardiac arrest, and then we always look back and see, okay, maybe this is genetic, or is it kind of there needs to be a pattern? I guess at that point it might be on the family to decide whether or not they deem it genetically related, and they have to search for you.
It's probably not fair to ask a family to recognize its own genetic risk.
Yeah.
Right? It's the right idea. Sadly, we sometimes see where two things have to happen in a family for somebody to connect the dots. And even sometimes it's sad, like there's a second death in a big family, and when that happens, somebody goes, this wasn't a coincidence, or this is something we need to be worried about, or my kids are at risk.
Okay.
Those kind of things. I think once people have had a problem, the system is reasonably good at saying, for instance, if you've had a cardiac arrest, there's a standard set of tests that are done.
Mm-hmm.
Part of this network has actually defined how testing should happen when you have a cardiac arrest to look for some of these genetic causes. That's something we've, if you like, contributed to the world, is what's called the Casper algorithm, which is how you get evaluated after a cardiac arrest.
Okay.
And it's looking for those genetic causes.
Okay.
Having said that, if we look at the conditions that we are examining for, investigating for, and you look at the likelihood that we've ascertained them, detected them, we think that we're picking up 20 to 30% of them. So most of them are undiscovered. And so part of the question is, how do we go about doing that? And the solutions aren't simple.
Okay.
Not everybody can have a comprehensive cardiac evaluation.
Right.
Lots of borderline tests happen when that takes place, and the whole question of screening is a different session for you.
Yeah.
But once they're in the system, we now at least have a good process for responding to their concern or recognition.
Okay. So Hero has how many clinics across Canada currently?
21.
21.
Yeah.
Okay.
Yeah. 4 of those are pediatric, where it's a children's hospital-based kind of thing, and the other 17 are for adults. They're basically almost in every province or territory. Some of the smaller populations don't necessarily have a big enough mass to have a clinic yet.
Okay.
But every one of those areas we have reached out and said, we want to help you if you have someone who wants to do this.
Right, very cool.
Yeah.
So these clinics, are you hoping to have one in every hospital in Canada?
So I think because it requires that sort of team of experts, it's maybe more a case of, that team of experts would be well suited to serve, for example, 1 million people,
okay,
or something along those lines. So, I think a good example would be, we don't need 17 clinics in Toronto,
yeah,
right? But we
definitely.
probably need 4 really good ones.
Right.
And they need to communicate with each other too.
Mm-hmm.
So, for instance, in BC, we have 4.5 million people. We have one children's center, a big adult center, and then a smaller adult center. So in Vancouver, Victoria, and then at the Children's Hospital. And that's probably not a bad recipe.
Mm-hmm.
And similarly, Halifax, which was actually the original cardiogenetics clinic in Canada, serves much of the Maritimes, including some of the smaller provinces.
Okay. And does each hero clinics communicate with another, or are we trying to do that?
So they do. The network involves, communication forums, if you like. The other thing is because we have an annual meeting where we all get together, so people actually know each other, first name basis, face to name kind of idea. And the other thing is because of the registries, we'll have families that we share.
Okay, very
So
interesting.
that cousin in Toronto, in Calgary, is in fact in the study too.
Wow.
And in fact, this week we had a patient who lived in Montreal and moved to Vancouver. And so in fact, they are in the registry, but now have a different follow-up site. But they have remained, if you like, part of the process, even by moving within Canada.
Right, very interesting. Thank you very much for talking to me about HERO. I've learned a lot during our interview today. Before I let you all go, I'd like to thank again the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society, Ottawa Student Chapter, the Department of BMI at the University of Ottawa and the Faculty of Medicine, and the Beats Research Lab, who are all supporting us here at Beats Research Radio. So thank you very much for tuning in, and we'll see you next week.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.